So we're going to move on to our last normal assessments, right? Looking at motor and sensory stuff. And we're going to be kind of focusing on motor parts. We're going to be looking at tone, strength, and reflexes. We're looking at the cerebellum as well, and a little bit about our dermatomes. So dermatomes, you get more when you talk about spinal cord injuries and such, about what dermatome level is being affected. Do they have absence of sensation at a certain level? And that's called anesthesia, right? Of course, pain will be involved. Temperature, touch, vibration, they can't be able to feel in that specific area, right? If you're looking at strength, we're looking at, cognition, we looked about more delirium. Coordination, definitely going to be a cerebellar assessment at that point, right? So we're going to look at all these different pieces for motor and sensory, our last little scrapes. All right, so normal motor assessment. We can look at range of motion, right? So range of motion is what you looked at in your first semester of nursing, right? You did a whole range of motion assessment, right? Shrug your shoulders, contract your biceps, relax, right? So you do that just head to toe when you're doing a full assessment, right? You're doing abduction, adduction, extension, flexion of the biceps, triceps, all the way down to see if they have abnormalities or not, right? All the way down to step on the gas or clutch. And if you say clutch, you're not going to people are going to tell you what that is nowadays. But you go step on the gas, and then of course putting your toes to your eyes, right? So that's range of motion. And then what about strength, right? So strength is where you have to have an examiner involved, and they have to assess if they can overcome the examiner's strength, right? You're not going to be trying to impress the patient. You're just trying to see, do they have more strength, or they have a loss of strength in one limb or the other, right? Or one half or the other, or the legs weaker than the arms, for instance, right? So if they are perfect, right, they overcome your push there, right? Now, on both extremities, that's 5 out of 5, right? If one extremity is weaker than that doesn't get a 5, right? The extremity that's the strongest, that overcame gravity, is a 5 out of 5, right? So what does it mean to overcome gravity? That means you lift your arm off the bed, right? You're able to lift the arm off the table of some sort, right? So if they're able to lift the extremity off the table, automatically they get a 3. Automatically, a 3. If they cannot lift their arm or hands or legs or feet or heels off the mattress, they are automatically a 2 or a 1 or a 0, right? But if they can lift it, they can move it off the bed, 3 automatically, right? If they have full power, 5. If they can just barely lift it off, one's definitely weak and falls back down, it might be a 3 or a 4. We got to use our judgment there, right? Also, resistance is there as well. So how do you know it's a 4 versus a 3? So they can lift their arms off both, or let's say feet, right? They can lift both heels off the bed with you pushing down, right? But if now for the different patient, you're pushing down on both their heels, the other one can move up against it, but the other one can't move off the bed with you pushing down. Now that's a 3. They can't overcome resistance, right? Whereas 4 is the other previous patient where they can lift both legs off the bed, but one is weaker than the other, right? With you pushing back on the patient, right? And then 0, 1, or 2, that's a patient that is can't overcome gravity, right? So either you see some effort, and they can maybe move a little bit, but they're not lifting that heel off the bed. They're not lifting that arm off the bed, right? But they can definitely move it around, right? If you're just seeing joint mobility, just joints, you can palpate that there's muscle activity, that's a 1. But if they're really moving the joints of the bed but they can't overcome gravity, then that's a 2. If they're not moving at all, nothing, that is a 0 or flaccid, right? Is what a patient with 0 to 5 strength, right? And technically you go through the whole thing again and you're looking to see what their strength is throughout their whole body, head to toe. Right? And then we have tone, right? So tone is our muscles' fasciculations, our muscles' ability to contract, right? Can it contract nothing? Is it unable to contract at all? Then yes, that is going to be flaccid, right? So that's going to coordinate with our 0 to 5 there. But if they contract normally, like you have full strength throughout the whole body, then you can say that is normal tone. But really, we have to look at is there any kind of spasticity or rigidity? Is there really, there's a rigidity in their movement? Is it smooth movement, or is it really stuttered? Or is there a lot of reflexive activity, which is called spasticity, right? Where it's very, very, like when you're trying to, pour a glass of milk for your friend, and like you don't want to look like a weak sauce, and you're like, I got this. I'm not gonna get weak as I pour this drink for you, right? So that's someone that has spasticity, right? Or is it even movement throughout, right? You've probably seen someone trying to get ambulated out of bed, and they're all shaking all over the place, right? That'd be someone who has more spasticity in their muscle tone. So someone who has normal tone is not as weak, right? Usually. And then we talk about upper motor neurons and lower motor neurons. We talk about the tone, because lower motor neurons are what provide the tone to the extremity, right? Our lower motor neurons provide little trophic factors, and these are what are going to cause the muscle to have strength and have more development, right? If you lose the lower motor neurons, you're going to have atrophied muscles, right? And they're going to then eventually become flaccid. And what do muscles do when they're dying? They wave goodbye. They spasticity. They have fasciculations, is another fancy word for spasticity. Okay, and then we'll talk about DTRs, right? So you can see in children, if they're flaccid or not, is another easier way to assess, but our patients usually are, you can't pick our patient up as easy as this guy. So continuing on our normal motor assessment, we look at DTRs, or deep tendon reflexes, right? DTRs are looking at the spinal reflex. When I tap on the patellar ligament here, it should then send a signal straight up to the spinal cord and then backtrack all the way to the muscle and cause the muscle to contract, right? So it's causing this quadriceps to contract, right? So it's stimulating the quadriceps, and muscles contract, they shorten, right? So then it's going to cause my muscle to contract, right? So that's a patellar reflex. We're assessing the level of the spinal cord at L3 to L4, for instance, right? So we can test that throughout the body at different key spots. We test it at the shoulders, we test it at the elbows, we test it at the knees, we test it at the heels. These are all different areas that we're testing a patient's DTRs, or deep tendon reflexes, right? And of course, they have more increased spasticity. It could be a muscle that is dying, yes, or it could be due to someone that has electrolyte issues. They get hypocalcemic or hypermagnesic, right? So these are problems with a lack of electrolytes to be able to maintain that muscle function, and that nerve is very, very hyperactive, right? So what's that fancy word? All right, it's not Greek, it's Russian. And then if Russian and French, you got Chevaustex, right? And you got Trousseau's signs, right? Those are because someone has increased DTRs, right? And clonus is something you can do, or clonus is where you move their foot like 5 times, and they then continue to vibrate their foot. All right, that's someone that has elevated DTRs, right? Normal DTRs are about 2+, and then of course they have increased or decreased, right? So we look at those things like within OB, they give them a lot of mag down there as a tocolytic, and they got to assess if the DTRs are getting depressed, right? Because then they can stop breathing. That's a sign that their diaphragm's not going to work either. Okay, so that's the idea behind DTRs, and we tested different areas: the Achilles, the biceps, the triceps. Right, we're looking to see if there is some kind of disease process that's occurring that's causing their DTRs to be increased or decreased. Like Guillain-Barré, for instance, has a decreased DTRs. That's one of its key findings. They have decreased DTRs to the progression of areflexia, because their spinal cord is literally being eaten up by the oligodendrocytes are being eaten up in the spinal cord. Okay, make sense? So clonus versus spasticity. So clonus is where you have, it's the same, it's very, very similar, right? It's a hyperreactive muscle, basically. And they specifically test it in the heels. Okay, but yes, it's a spastic muscle because it could be electrolytes, it could be a disease process, right? Where they're lacking for instance, they're lacking the upper motor neuron lesions. Right, their upper motor neurons are not there to inhibit that reflex down at the base, right? So that reflex is very, very prominent, right? Because the upper motor neurons from up here are not inhibiting it, okay? So upper motor neuron versus lower motor neuron, that's where you have, we kind of mentioned this when we talked about neuro to begin with, that we have it's basically CNS versus peripheral nervous system, right? So upper motor neuron is everything in the CNS, right? So the CNS starting all the way from the cortex all the way down to the spinal cord, just until it leaves the spinal cord, that is all an upper motor neuron. The spinal tracts, everything is upper motor neurons, right? And what upper motor neurons do, they either inhibit or they allow an action to happen, right? We have our basal ganglia involved here as well. So it is involved at making that a nice smooth movement, for instance, like in Parkinson's, right? So these are all, you say, I want to move my leg, right? And you send a signal down from your motor cortex. For some reason, it like just it's created in the netherverse and in your parietal lobes. You decide, oh, today's the day I'm moving my leg, and then it gets made, and then you go to the area of the brain that's going to send off the signal, right? So we initiate that impulse. So we don't know how that happens. We don't know how we create a thought. We're just pretty crazy, right? Just like, how do we even make my foot move, right? Where does that impulse come from? We just know it happens. Anyways, enough existential talk. So it's going to go to that our precentral gyrus, and that's going to then, we know once the impulse it happens there, and we can go to neurosurgery and we just poke that area, right? And we activate that area. It's going to cause my leg to move, right? So I go all the way to my legs, probably more up here actually, but anyways, it goes all the way down this upper motor neuron, and I make sure that leg moves nice and smooth, right? You've probably seen a baby walk or someone with Parkinson's walk, and they don't have a nice gait, right? They have a very rigid gait, whereas someone that has, evolved with a cerebellum involvement and other things, they're able to have a nice smooth movement. Okay, so that's our upper motor neuron. It's what provides the inhibition and activation of a muscle very, very, very smoothly, right? So when I have a stroke, for instance, I cannot move that muscle smoothly. If you watch someone rehabilitating from a stroke, it's just like they're walking again, or just like they're moving their arm again with occupational therapy, for instance, right? Traumatic brain injury, multiple sclerosis, cerebral palsy, spinal cord injury, all these things are upper motor neuron diseases, right? ALS, for instance, affects just the spinal cord, and that's a upper motor neuron disease, right? So we lack that upper motor neuron to provide its inhibition of our periphery. So we look at Babinski's reflex, right? Which again is not a reflex, it's a Babinski sign. So you're going to have a Babinski sign when you have upper motor neuron lesions. Because what is Babinski? It's doing its own thing, right? It's going to do its own reflex down there. Usually we can inhibit it. That's what we do as adults, right? Our spinal cord develops after age, 2 or whatever it is, all the way down to be able to inhibit the Babinski. But before age 2, before 18 months, Babinski sign is okay, right? But after that, it's not okay to have a Babinski. All right, so we usually inhibit that with our upper motor neurons. But if we have a upper motor neuron lesion or disease or tumor or bleed or stroke or cerebral palsy or spinal cord injury, then you're going to have that's present, right? You're going to have that lower motor neuron present. The reflexes are still present after the spinal cord. So the reflexes down here are still doing their own thing, right? They will eventually wean off because your body's a use it or lose it system. Eventually, if you don't use it, it will get lost, okay? And then lower motor neuron diseases. So this is where we have a peripheral nervous system versus CNS. Our CNS is up there. Now our peripheral nervous system is being evolved. Our motor system is being evolved. We're talking about motor right now, right? So like myasthenia gravis, it works on the muscles, right? Right at the muscular junctions. We got ALS, I could probably put up top. It's kind of happens in both a little bit, but it's mostly spinal cord. Guillain-Barré down in the spinal cord. It also works on these guys here. Botulism, polio, the reflexes are suppressed. I don't have reflexes because why? Well, they are being destroyed. Something's destroying that reflex, that lower motor neuron reflex, right? So reflexes are suppressed, right? I got decreased tone and decreased DTRs, and I'm gonna get atrophy. Why atrophy? Because those lower motor neurons not only provide that muscle input, but they also provide these little growth factors for my muscle, right? So you're going to see a deterioration of those muscles. You see atrophy of the muscles. Before they completely atrophy, they do wave goodbye. They do get fasciculations. They do have a little spasticity until there's no activity at all. Okay, so that's the difference between lower motor neurons and upper motor neurons, right? And we can tell based on assessment what's going on, if it's an upper motor neuron situation or a lower motor neuron. All right, then cerebellar. All right, so cerebellar, that's not our cerebrum, which is up top, our cerebral cortex with a few different nuclei in there, like a basal ganglia, limbic system, etc. Now we're talking about the cerebellum, right? So cerebellum is an amazing system. It's very, very small, and it actually has 70 billion neurons compared to the cerebrum, which only has 16, right? So it's almost about 4 to 5 times more neurons, just this little ball sack right underneath the brain, right? It's a little box within a box, so it has its own little tentorium there. its own little space right there compared to the cerebrum, which can expand a lot. So when you ever have a cerebellar dysfunction or cerebellar edema, a cerebellar bleed, it's much more high risk compared to a cerebral bleed or cortical bleed. Okay, but what does it do normally for movement? It causes coordinated movement, be able to play the piano, be able to pass a sobriety test, right? So that she's not passed that sobriety test, right? So that's, you know, when you have your cerebellum is inhibited when you have alcohol ingestion, for instance, right? So your cerebellum goes offline and you have an inadequate ability to walk straight or walk the line, and you don't have good coordinated movement. Your muscle memory goes offline, right? So you forget how to walk, you forget how to do things normally. All right, so you have this coordinated movement right here. What's that movement called? Where they're able to do a fast movement in their hands, right? Back and forth, back and forth. It's a way to tell if someone has like multiple sclerosis. They can't do that movement because their cerebellum starts getting lesions in it, right? So that movement is called dysdiadochokinesia. Close, right? So yeah, so that's a dysdiadochokinesia test where you can have them move their hand back and forth, and they can do that. Their cerebellum is intact. If they can't, that's a problem, right? And they also have, you know, the coordination. You do this in your NIH stroke scale, right? You have them do the shin test where they move their shin across their heels, or the heel across their shin, I should say, right? So these are things we do with our NIH, right? To assess someone's cerebellar function, because you can have a cerebellar bleed, you can have a cerebellar stroke. So that's what we're looking for when we're doing the NIH stroke scale. Okay. Also good for posture and balance. You have a lot of muscles that keep you upright, and you don't think about it. You do think about when you're slouching, like, oh shoot, I got to sit it back up. I look like a slouch, right? But then, but when you're walking around, you're not really thinking about keeping yourself upright. So your cerebellum is responsible for that. All right. So coordination, gait, proprioception, awareness of your body in space. Someone with like multiple sclerosis, for instance, that has lesions in the cerebellum, right? Or even someone like ADHD, they can't keep their cerebellum online at all times, so they're always dropping stuff. They're always like hitting themselves into walls, right? So you'll notice this in the unit, because ICU nurses usually have ADHD. And they're like dropping things, or they're knocking themselves into walls, or like they're bumping, like you see all the patches along the hallways with the beds, right? Or knocking beds into walls all the time, right? So that's a feature, or not a feature, right? It's not a bug, it's a feature of someone who's ICU nurse. Okay, so you can do like a Romberg test to hold the pizza, to be able to tell if someone's cerebellum is actually dysfunction. And nystagmus is another feature as well. It keeps your eyes midline, so your eyes aren't moving all over the place as well. It's always keeping your eyes where it needs to be, which is another cerebellar function. So an example of that.
That's a good one.
That's called child abuse. She's gonna fall over. Anyways, that's an example of an nystagmus. Our cerebellum is trying to keep us intact. Whereas if that child has drank alcohol, so then she's not gonna be able to have good coordination afterwards. Don't feed your children alcohol, please. All right. So sensory assessments. So sensory assessments are where you're assessing dermatomes, right? Dermatomes have different levels, like T4s of the nipples. You have, the tip of the shoulder is C5. All right, there's T4 right there. T10 is the umbilicus. There's a little mnemonics here and there to figure out where the dermatomes are. But it doesn't make sense when someone's standing upright, but it makes perfect sense when someone stands, lays over, right? Because it has like the horse dermatomes are very similar. Animals have the same kind of dermatome mapping like the humans do if humans were lean over like this, right? So then now it lines up nice and even for us, so we can clearly see where things are going, right? So when you look at it upright, it makes no sense about how dermatomes are where they are. Right, so what are you assessing sensory-wise? You're assessing whether they can feel touch, whether they have pain with little pins, right? So, temperature, hot versus cold, right? Vibration, you have like a tuning fork. You can assess vibration on different joints. And then discrimination. You'll be able to see if they're able to tell a difference between 2 points or not, right? On the hands, you should be able to, because we know we have a lot of sensory fibers dedicated to that compared to like an elbow, right? So the face, for instance, or the hands or the feet. And you can do graphesthesia. You can draw a letter in their hand, or you draw a little heart. It might be awkward, but what did I draw for you, right? You're like number 3 or number 2 or number 1, right? And stereognosis, that's the ability to perceive a familiar object where they're able to put their hand in their purse and you find your chapstick immediately, right? So that's where you know what it looks like without even looking. People who don't have that, they have to look through it and be able to see exactly what's going on. Okay, so here's an example of a normal neuro exam.
Sensation in the upper extremity consists of a number of modalities. Ideally, light touch is best assessed using cotton buds, just making sure that they feel that with their eyes closed. You just have them say touch each time that you touch them. Make sure it feels about the same on both sides. Pin prick is best assessed, as the name would suggest, with a pin, which should feel sharp in particular. This is C5 region, the patch region of the shoulder. This is C6, C7 localizes the middle finger, C8 is up here, and T1 will be up in the armpit. Again, you want to compare like with like. If one side does have abnormality, the other side is normal. You can tell the patient if the normal side is worth $1, how much value does the other side carry, especially for people who have difficult time with percentages. So, for example, if this feels normal and it's worth $1, how much is this worth? 50 cents, a quarter, something to that effect. Additionally, you want to assess vibration, both of the upper and lower extremity. You can do this simply by having them close their eyes, hit your tuning fork, put it on the first joint, and at this stage ask them if they feel a buzz. Do you feel a buzz, sir?
Yes.
And with your eyes closed, tell me when it stops.
Now.
Excellent. You do the same thing on the opposite hand. Additionally, you can assess proprioception while they're here. Ask them to keep their eyes closed, and then grabbing the joint on the sides of the joint, and the finger on the sides of the finger, you can tell them with their eyes closed, this is up, this is down. Move it around a bit, and then stop in one location. Is this up or down?
Up.
Excellent. And now?
Down.
Very good. If they're unable to get that at that stage, simply move on to the next joint. And again, with their eyes closed, tell them this position is up, this position is down. Move it around a little bit, stop in one position. Ask them, is that up or down?
Up.
Very good. And now?
Down.
Very good.
All right, so that's looking at the upper extremities, the example of the lower extremities.
Sensation in the lower extremity can also be assessed both by light touch as well as pinprick, as we saw in the upper extremity. Again, the same thing, having them close their eyes and just touching them and asking them to make sure that they can feel you touching them. Ideally, the cotton wisp for light touch. And for pinprick, again, our pin comes back out. In terms of the dermatomal distribution for each of these, L1 is usually found in the ilioinguinal canal, L2 sort of in the proximal portion of the thigh, L3 localizes to the knee quite well, L4 is more medial aspect, L5 can be found at the top of the foot, and S1 on the very side of the foot. And you'd want to compare like with like, and compare the severity of any decrease in sensation, or decrease of sharpness that they might have. Similarly, in the lower extremity, you can also assess vibration and proprioception in the same sort of format. Again, asking them to close their eyes, tap your tuning fork, place it on the first joint, asking if they feel that buzz. Can you feel that, sir?
Yes.
And tell me when it stops.
Now.
Excellent. Proprioception is done the same way, again, touching the sides of the joint and touching the sides of the toe and moving the toe again with your eyes closed. And if this is up and this is down, up or down?
Up.
Excellent. And now?
Down.
Excellent. And similarly, along the same lines, if they have difficulty with that, the first joint, you can move on to the second joint. You're simply move the toe up and down, and the same. Additionally, vibration both in the foot as well as in the upper extremity. If they don't feel it at that first joint, due to, say, for example, peripheral neuropathy, for example, you simply need to move up to the next available joint, in this case, the ankle, and repeat.
All right, so that's the idea. So now we're going to put all that together, and you're going to put in your British accent, fly British flag, and be able to listen to a complete neuro exam.
First of all, stand with your feet together and close your eyes. Keep your eyes closed for a moment. Open your eyes. Can you walk heel to toe like this? Good. Walk on tiptoes. Walk on your heels. That's lovely. Hold your arms out like this with your palms flat.
So cerebellar.
Close your eyes. Keep your hands where they are. Keep those fingers straight if you can. That's lovely. Let's keep still like that for a moment. And now with your eyes still closed, touch your nose with this fingertip. And with this fingertip. Good. Open your eyes. Play the piano. Good. And tap your hand. Other hand. That's good. Now turn and face me. And screw your eyes up tight. Lovely. Relax. And silly grin. Stick your tongue out. Wiggle it. That's lovely. Stare at my face. Point at the fingers which move. Now stare at my face. Let's point at the finger. That's it. Look at my face if you can bear it, point at the fingers that move, and stare at my finger. Now keep your head still and just follow the finger. Look at the finger, follow that finger, that's lovely. Excellent. And now can you lie on the couch, please? Okay, just going to tap your reflexes here. Going to scratch your foot, you won't like this. And again, lovely, isn't it? And stare straight up at the ceiling, just going to look in the back of your eye here. Keep looking through my head. And look over there. Excellent, you passed with flying colours.
All right, so he kind of mixed up all the cranial nerves, which is cool.
Of course you need to understand the method behind all of this madness.
So you're not sitting up
which I
and
shall
sitting
now
down,
explain.
sitting up, sitting down.
Starting with Romberg's test, a very important test. We can all usually stand with our feet together and our eyes closed, but normals wobble a little bit more with their eyes closed. That's not abnormal. Some people are very anxious when doing Romberg's test and are all over the place. That can be non-organic, and you'll pick those patients up when you try and get them to do tandem gait. And having wobbled everywhere with Romberg's test, then when they do tandem gait, no problem at all, even with my hands in the pockets and walking backwards. While in the ministry of silly walks, the patient should be asked to walk on their heels and on their toes, which is a very quick and useful test of the power of dorsiflexion and plantar flexion. When looking for drift of the outstretched hands, ask the patient to stretch their hands out as far as they can and get the palms flat, fingers straight, as though holding a tray from underneath. Once the patient's got the message, close their eyes, and in normals the hands should stay in the same place. But if I've got a left hemisphere lesion, the right hand may do that, or if I have neglect, it may fall away like this. But hopefully it will stay put, and with the patient still in that position, you can then test light touch by touching first, for example, their index finger, and asking them to touch their nose, and then their middle finger. So you've tested light touch and a finger-nose test. Testing rapid tapping movements is a very useful screen for ataxia, and if you're concerned, you can make the patient do it in a more difficult way, like that. Most people are better with their dominant than with their non-dominant hand, and the same applies to fine finger movements, a very useful test of pyramidal function. And while you're fiddling around with your hands, then move straight on to testing the visual fields. I do this with both eyes open and the patient staring at my face or at my nose, and you have to remind them to keep staring at your ugly face and to point at the fingers which move. I test one side, then the other, and then both together to check for inattention. The reason I think this is acceptable is because you hardly ever see people with an isolated nasal field defect. Important visual field defects always involve one or other temporal fields, and of course if there's an abnormality, then you'll want to go on to test in more detail, perhaps with a red pen. After that, one moves on to looking at the face. Get the patient to screw their eyes up tight, check they can bury their eyelashes. When they open their eyes, check and see that the pupils come down nicely to light. And while you're looking at the eyes and pupils, have a quick squint to see if they have Horner's syndrome, which is most easily recognized by looking for the quizzically raised eyebrow, more wrinkles on that side. Then you focus in and look and see if they've got a droopy eyelid. And of course, the small pupil is much better seen in the half dark than in full light. Then onto the lower face. Silly grin, should be nice and symmetrical, and rapid tongue movements. Tongue out, like that. Patients usually find that relatively entertaining, except the ones with a pseudo-bulbar palsy, tongue movement. It doesn't do what it's told. After that, it's onto the couch for the tendon reflexes and fundoscopy, about which you need no instruction, although if you feel unhappy about them, it's simply a matter of practice. While the patient's on the couch, of course you'll check the blood pressure, and in older people with headaches, you will probably want to screen for primary neoplasm, palpate the breasts, abdomen, examine the chest, and then you're done.